And our first speaker today is from Houston Methodist. Dr. Jason Alexandra did his training at Columbia as a resident and did his fellowship at Texas Heart. Also did a critical care fellowship at Columbia, yes. And now he is going to present heart transplantation.
All righty. Let's see. Okay. So timer already started. 15 minutes to teach everything I know about heart transplant, right? This is going to basically be very, very general in terms of our concepts. This is what I'd like to cover. I don't know if we're going to get to all of it. It's the overall basic summary. So when you're coming up with a lecture on how to talk about heart transplants, over 15 minutes, I tried to come up with a goal. And what I realized was I can't go over things that you can Google search. So if you want to learn about criteria, exclusion criteria, how we list people, you go to Google and you just put in this article, it will come up. So today's talk is only meant to inform you of things that I think the books aren't going to teach you. Okay, there's nuances and pitfalls to heart transplantation. The way that most of us learned is early on in our career, we made a few mistakes and learned from those mistakes. I'm going to try to get you to a point where you won't be making those kinds of mistakes that most new attendings kind of hit. So preoperatively, you guys already know this. Majority of heart transplants are going to be dilated cardiomyopathy. It's multiple etiologies. The real takeaway from this slide is that second bullet point. These people have a fixed low stroke volume. They are heart rate dependent, preload dependent. They don't have contractility, right? So they can't generate more cardiac output by squeezing harder, so it's preload and heart rate that's going to be the important thing. The second thing is a compensatory increase in your SVR. So that's the takeaway. 3 things to maintain in your heart transplants. Preload, heart rate, and SVR. If you mess with any one of those, your patient can do poorly. The echo findings are going to be pretty consistent with everything you've seen in residency. The important things that I look out for is severe TR that's long-standing because that's going to lead to hepatic dysfunction, and RV failure because that makes the entire transplant a little more tricky. Your appearance of your patients are going to vary. I've had people who are totally healthy appearing, just here for refractory angina, whose echoes are essentially normal, to the combined heart-liver transplant patients who look like they're going to die at any moment. Some are going to have pre-existing VADs as bridge to transplant. Others are going to be just coming in from home, and others are going to be in the CCU for anywhere from 1 to 2 weeks on inotropes, intubated possibly. So what are we going to look out for in these transplants? Obviously, you're going to do everything they taught you in residency, right, in terms of a pre-op. Specifically to cardiac, these are the things that I think you have to really focus on. So you got to look at their previous echo, and what we're looking for specifically, in addition to everything, is RV function, PA pressures, and severe TR, and we kind of alluded to why those things are important, okay? On the chest x-ray, I like to see if they have huge pleural effusions. That's going to play a role when it's time to induce this patient, right? Your FRC is going to be reduced severely. They may not be able to lay flat. Obviously, you want to look at inotropes, vasopressors. Most of these patients are on some form of anticoagulation, so it's up to you to find out how much they're on, what their coagulation studies are, when they stopped it, and then have a discussion with your surgeon as to what's the plan in terms of reversing or seeing if you could do it without reversing. Take a look at the LVAD parameters so you have a baseline. A few more things that you're going to have to investigate and coordinate. So allergies are important, especially HIT. If your patient is HIT positive, you immediately call your hematologist, pathologist, surgeon, come up with a game plan as to what you're going to do. That varies by institution. NPO status, a lot of times these guys are coming in from home. They may have just eaten. You have to take that into account before you start getting ready for your induction. You want to look at previous anesthetics. Was he a difficult airway in the past? I like to know stroke risks, TIA risks, because that's something that appears in cardiac surgery more frequently than other types of surgery. Dysphagia and GI bleeding is the big one that fellows initially forget to ask because it's not the common ones you ask, right? You're going to be placing an echo probe in someone. You need to know if they have dysphagia. GI bleeding is really important. We know LVAD patients have a higher risk of GI bleeding. We know most of these people are going to be on anticoagulation for AFib or previous clots in the heart as well. So if somebody is telling you that they're having GI bleeding, that's going to contribute to your conversation of, hey, should we reverse this guy to a somewhat normal INR before you start putting in an echo probe into the patient? Immunosuppression and antibiotics is going to be per institution. You should talk to the transplant team regarding that. So a couple of pitfalls that I've seen and I've personally experienced. Pre-medication, we kind of take for granted, right? 2 of Versed and 50 of fentanyl, right? Almost everyone can tolerate that, but you're going to see a subset of patients who will not tolerate this. And this is going to be your sickest of your sick patients, right? So the ones who can't do any normal daily living, right? So your class 4 heart failure, essentially. So these guys are kind of surviving on stress catechols. When you take away any kind of sympathetic to them, they don't tolerate it. A lot of them have pre-existing RV failure or pulmonary hypertension. That's a deadly combo to give someone fentanyl and Versed and cause hypoventilation, right? The hypercarbia is really going to play a role in how this patient does. Most of the time when we give these pre-medications, it tends to be in an interim of less monitoring. So we're moving from pre-op to the OR, or we got into the OR, now we're moving to the bed and the patient's anxious, so we give it. It's a risky time to not be monitoring the patient, so at least you have to pay very close attention to how the patient is appearing. My personal pet peeve is the second one. Do not exert your patient right before you're about to give him an anesthetic, okay? You're going to hear this a lot where they say, do you think you can move over? The guy can't brush his teeth without getting short of breath, okay? But do you think the patient's going to say that? No, they're always going to try, okay? So I had the unfortunate event of a patient going into RVR while we were moving over. Obviously, none of your monitors are really hooked up because we're moving. We had to shock him emergently. It was a mess. Okay, so my general rule of practice is we should be moving these patients. They should do absolutely nothing before you're about to give them an anesthetic. Along with that is what we see, first-time resident or fellows come in. When you move them over, they drop the bed completely flat. A lot of these patients can't tolerate that move, especially if their RVs are tenuous. Okay, they can't take the volume shifts. So be careful, and that's why you're going to look on your echo and your chest X-ray for pleural effusions and, more importantly, pericardial effusions. We had that a few days ago, and it played a role in how the patient did in terms of an induction. This stuff we're going to basically skip over. You guys know you're going to need the monitors that you need, right? We don't have to really go into this. Please do not stop inotropes or vasopressors that were started in the CCU. People do this mainly for one reason. They don't want to transport the pump, and so they just start shutting things off. I don't understand why, but I've seen this multiple times. If the CCU took, 3 days to get that ready, you probably don't want to be shutting that off right before you're going to stress the patient. So take a look at this. This is a record of induction, right? This is just a typical thing that we see now. I don't know how many of you guys induce cardiac patients with propofol. Anyone? Raise your hands. Yeah, it looks like it's like the Methodist people. We induce with propofol. It can be done. We do it routinely. The key is knowing how to use that drug, and the same goes for anything, right?